was okay.
Okay, well, hello. I did the registrar teaching this afternoon and used the allergan arm, which help you to localize the muscles for botulinum toxin to manage spasticity. So I took it with me home this evening and just play with it a little bit, and I thought that I will try to give a bit of demonstration about the injection of the common muscles that we inject for spasticity. So the way that the machine works is that it will give you scenarios like flexed elbow or clenched fist, and it will suggest the muscle to inject it, and of course it will be up to you to follow what it does according to the clinical situation. So we'll start with the flexed elbow, which is a very common problem, and they suggest injecting 4 muscles: biceps, brachialis, brachioradialis, and pronator teres, which is mainly pronator, but it helps with the flexion a little bit. So for the biceps, I think most people will have 2 sides of injections in either side. So it will be in here and in here, and the muscle, of course, is usually very easy to localize. The brachialis is behind the biceps, and the best way to do it is just to have about 2 fingers above the elbow, and then go about 45 degrees towards the humerus. And you'll find that it is relatively, this is the best approach for it. If you look at the needle, this is almost 4 millimeters. So this is a very easy, because if you go through the biceps in here, you will have to go very deep to hit the biceps first, and then go even deeper to hit the brachialis. So it's a little bit uncomfortable for the patient. The brachioradialis usually is very easy to localize in the lateral aspect, and usually it is quite spastic and appear. It is a relatively superficial muscle, so you don't need to go very, very deep to hit it. And actually, if you go very deep, usually you will go through it and you will not catch it smoothly. So it is usually an easy muscle to find. The pronator tear is usually a bit difficult to palpate. Again, let's have 2 fingers, and just in the middle of the arm, and that usually get you, again, relatively superficial, and get you the pronator teres. So these are the 4 muscles that we use for the elbow flexion. So we'll move now to another deformity once just to get the machine to work. So pronation of the forearm, which again is a very difficult problem and very, very common. Most of the people will come to you with pronation and you want to supinate a little bit. We already picked up the pronator teres, again, about 2 fingers, relatively superficial in the middle. And then there is the pronator quadratus, which is like a little band in here. And you have about 3 fingers in here, and again you go in the middle. So the flexor digitorum profundus usually is in the top of it, and if you go through it, you will hit the pronator quadratus. And sometime if you probably go a little bit down, you can hit it straight away. No, we still the flexor digitorum profundus, and under it the pronator quadratus. Of course, with most of these cases, you will need to inject the flexor digitorum profundus as well, so that's really not a big problem. So after the pronation, let's look at the clenched fist, which again we see a lot with the stroke. And they suggested the 2 wrist and the finger flexors, flexor digitorum profundus and flexor digitorum superficialis, and with it the flexor pollicis longus, which again work proximally on the finger as well, and the lumbricals. So the flexor digitorum superficialis is a relatively big muscle in here in the medial aspect. Again, usually it is easy to palpate and relatively, again, superficial. Flexor digitorum profundus, a large muscle that usually start here below the flexor digitorum superficialis and then go like that. And it is, again, most of the people tell you go have two, so 1/3, 1/3, 1/3, and try to go into between the lower 1/3 and the upper 2/3, because that's probably is the best place to find the flexor digitorum profundus. And after that, the flexor pollicis longus, again with this same idea. So we are talking about this between the lower third and the upper 2/3, and it is almost like you are picking up the pulse. So it is relatively easy to find a muscle. It's usually a bit difficult to palpate, but again, it is relatively easy to find. The lumbricals are the muscles usually between the fingers. So if you go, say, in here, let's try here. It's a bit difficult to do. So the lumbricals are between the two fingers and more or less in the middle of the palm. So this is the regime they suggest for the clenched wrist. Flexed wrist, which is more or less the same actually, but with the wrist, flexed wrist, probably you will focus with the muscles we talked about, with the flexor carpi radialis and flexor carpi ulnaris, which are relatively, again, big muscles and easy to locate. So the flexor carpi ulnaris is in the median aspect. In most patients, it is palpable, so it's very easy for you to pick it up. And then the flexor carpi radialis is very close to the pronator teres. They are usually, if you do ultrasound, you'll find them very, very close together. So this is the flexor carpi radialis. The pronator teres will be just in here. And then we'll go again with the flexor digitorum superficialis and profundus. So flexor digitorum superficialis, so we have pronator teres, we have flexor carpi radialis, and then the flexor digitorum superficialis like this and go under them as well. So if you are using something which, so it's a tiny bit deeper because it go under the flexor carpi radialis, and as we agreed, the 1/3 and 2/3 to get the flexor carpi, the flexor digitorum profundus. Flexor pollicis longus, they suggested as well. You say as well here suggest the flexor palmaris longus. It's relatively difficult, and once you inject those, probably the botulinum toxin will go to it, but it is very close to the other muscles. So this is still flexor digitorum superficialis. It can be a little bit difficult to locate. So this is the rest for the wrist flexion. The last one is the thumb and palm, which again is very, very common. So the flexor pollicis longus, we already agreed where it is. And then you have the flexor pollicis brevis, which these are, you will start to work in the thinner muscle. This usually is a little bit painful for the patient. So I usually try to use orange or very small needle because the skin here is thick. So the flexor is more or less in this area. And then the adductor pollicis, it comes like that. So you have to take it a little bit in this area, and that's usually the abductor pollicis. So these are the common muscles usually we inject with the arm. And of course, it's very, very difficult for you when there is function in the arm, because you have to tell the patient that they may lose some function. So the assessment with people with functional ability in the arm, it should be a little bit, you have to be more careful with the people with non-functional hands. Okay, well, thank you.